What happens when your shoulder is actually aching? Doesn't it really hurts? Actually, shoulder ache is quite a problem, especially if you are a young person who also happens to be an athlete as well. It's quite a problem. It's possibly for people who are athletes, it could be a career ending problem. So first we are going to be coming towards some form of anatomy of the shoulder. Before we go on to discuss the instability, what we need to understand is actually what is the anatomy of the shoulder joint. If you see it over here, this is the glenoid cavity. This is the head of the humerus. What actually, it's like a T on a ball kind of a situation. Have you seen that golf tee, which is quite actually a small one, and it's a big ball which is actually resting on it. The advantage of this is actually it provides a lot of movement. There is a lot of movement which can take place at the shoulder joint, whether in form of abduction, adduction, forward flexion, backward extension, or even the circumduction. But what actually happens is it inherently produces instability at the shoulder joint as well. Then you have restraints like static restraints, which are the actually glenohumeral ligaments, which further include superior, middle, and inferior glenohumeral ligaments. Then you have static restraints such as the glenoid labrum, which is actually attached right around it, and it's kind of a rubber seal which actually provides and increases the depth of the glenoid. And then you have a capsule which is also around the glenoid labrum, which is acting as a static stabilizer. Above that, then there are dynamic stabilizers as well. These dynamic stabilizers are actually muscles. They have actually a kind of a sling effect, that when you are moving the shoulder, there is definitely some degree of movement of the humerus head, either anteriorly or posteriorly or above or below. But that is actually maintained in a certain level, and this head does not subluxate or dislocates. But if there is a problem with either these muscles or these with the static stabilizers like ligaments, for example, there is a Bankart lesion in which there is an anterior inferior capsular as well as labral tear. Then when the patient would be like throwing the ball, the head would subluxate initially anteriorly, but there will be no restraint. As a result, it either subluxates or dislocates anteriorly. And this is what actually happens in the instability. There is something wrong with these restraints, either the static ones or the dynamic ones. For example, the muscle patterning is not good enough for rotator cuff. The external rotators like supraspinatus and infraspinatus, these are not acting in unison. As a result, either there is increased external rotation or decrease, or for example, the subscapularis is not in a good condition. As a result, there is massive external rotation, and therefore the increased restraint actually on the posterior capsule and posterior labrum. So before you understand the concept of instability, you have to understand that by design the shoulder joint is such that to produce a lot of movement over it, what has actually happened is that some form of stability has been compromised. But when this compromise goes beyond a certain point, this actually produces the instability, which can be appreciated right over here. Now, this may be happening when a person is throwing a ball, that there is definitely some movement, but as the anterior restraints were lacking, the result, the head completely dislocated out. So it's basically the instability of the shoulder. The primary problem with the acute traumatic instability is always the dislocation. Dislocation could be mostly it's considered the anterior posterior, but there's also inferior dislocation as well. Most commonly it is the anterior dislocation, in which the head actually dislocates anteriorly. And what actually happens is when the head dislocates anteriorly, the structures which are actually damaged are mainly the anterior side, that is the labrum as well as the capsule, and the structures which especially the anterior inferior glenohumeral ligaments. Or it can go posteriorly, although posterior is way too less. It's usually common only in certain conditions, for example in epileptics, or those patients who are undergoing electrocution injury. For example, sudden jerk can produce this posterior dislocation. There is a rare form which is less than 0.5% called as inferior subluxation and inferior dislocation. Now this inferior dislocation, although is less than 0.5%, but it has a specific mechanism in which the arm was above the head at the time, and for example there was something falling on the top of the person and he tried to protect himself. In this kind of a situation, usually the force is acting in such a way that it's actually pushing the olecranon like downwards, and eventually this head goes into an inferior dislocated position. As the inferior capsule is quite lax and quite thinner, it quickly dislocates into an inferior dislocation, but that is quite rare because you need a specific kind of a biomechanics and conditions in which this kind of a situation can occur. Most commonly it's always the anterior dislocation. Now coming to the subluxation, as I told you, that dislocation is complete movement out of the socket joint, and subluxation is that there is partial movement, although the joint remains intact, but partially it is actually subluxed. This is called as the subluxation. Now there is a pathogenetic classification for instability, and this is actually quite useful in terms of it. This is being called as polar types. As you know, by definition, the poles are actually at the end of it. The end spectrum could be, it could present with classical picture, it can present with something in between as well. So this is when we are clinically evaluating a patient, we need to understand it, that is the patient is at the pole of the problem, that is there is a classical presentation, or is it something in between? Sometimes it's quite in between as well. For example, type 1 is, or polar type 1 is actually traumatic structural. What happens in this patient had acute anterior dislocation. When this was an anteriorly dislocating, although there was ligamentous injury, capsular injury, but also this resulted in anterior inferior glenoid fracture as well. That structure is lost as well. Now what happens is, when this glenoid heals out, despite the adequate reduction, as by any definition for any dislocation you have to first go for close reduction. But despite close reduction, and which is adequate enough, this may produce a kind of a bony deformity in which there is actually space is available for the head to redislocate again and again anteriorly. This is classical traumatic structural type of a presentation. Other type could be that this could still be a traumatic type, but there may not be associated with the fracture of the anterior inferior portion of the glenoid. Now this may not be classical presentation, but this still would be considered traumatic type of polar type 1 injury. That is why, but although the patient not exactly at the poles of the, our classical representation is not there. Other is type 2 injury or type 3 injury. Now type 2 is atraumatic structural. For example, the patient had a problem with, for example, there was a glenoid dysplasia, in which there was a deficient glenoid in form of a bony component. This deficiency of the component can actually lead to recurrent dislocation and subluxations, initiating instability. This is classical polar type 2, but there could be something in between as well. For example, there may be no associated dysplasia, but what is actually happening is that the head may be too much retroverted. On average, what happens is there's 0 to 5 degree of retroversion of glenoid and 20 to 25 degree of head. For example, if the head is retroverted or if it's too much antiverted, this would result in either posterior and anterior dislocation respectively for the humeral head. So what is important to understand this, there may be not a classical presentation, but there will be some form of a structural deficiency which may be precluding a patient to increase instability and dislocation. Another type 3 is actually a muscle patterning type, which is actually the problem is not with the bony structures but with the muscles. That is, they are not acting in a unison, so that they cannot create that sling effect. When the head is moving during the motion of the shoulder joint, they cannot create a sling effect to make it stay there in the glenoid. As a result, either it dislocates anteriorly or posteriorly. Now coming to the further enhancing it over the type 1 injury, which I just told you was actually the polar type 1 was traumatic structural instability. There is always a history of trauma. Patient complains to you that the patient had an RTA, there was a fall, there was something happened with the shoulder. Then there is associated articular surface damage. There are two types of it. This is called as bony Bankart and ligamentous. The bony Bankart lesion could be a result of it when there is dislocation associated with anterior inferior glenoid fracture as well, and there is associated articular surface damage. Or it could be a capsular problem. That is, with the ligamentous Bankart is that there is anterior inferior labral lesion along with the capsule tear. Head is coming out without any bony fracture. There is when you have a capsular problem or a Bankart lesion. Then it produces the laxity. How would it produce a laxity? Despite close reduction, there may be not adequate fibrosis of the joint, and it actually has resulted in a large globular kind of a labrum as well as the capsule. Now this is extra space available help to again come and out, so it actually kind of produces more of a laxity, and which is usually unilateral because it is going to only occur in the shoulder which has suffered trauma. It's not going to be bilateral laxity. Muscle patterning is usually normal in this type of instability. Then coming to the type 2, which was actually atraumatic structural type. Here there is usually no associated history of a trauma, but what happens is if the trauma has occurred, let's see 1 year or 6 months ago, now the patient complains that I had an injury, there was a dislocation, it got reduced, I started working, but now when I work there is always I feel as if my shoulder is giving way and it's actually going to come out. So usually there is no antecedent history, but there may be a past old history of trauma which may be associated with articular surface damage. Then there may be associated capsular damage, which is usually capsule in most cases dysfunctional, along with laxity. Laxity could be unilateral or bilateral. If the problem was traumatic, which happened quite a long time ago, and now the patient is feeling the problem of laxity and capsular dysfunction, then it is most likely going to be unilateral, but it could be associated with some sort of a structural abnormality which could be bilateral as well. So laxity could be unilateral or even it could be bilateral. Muscle patterning in this case is mostly normal. Then comes the type 3. Type 3 was in which the muscle patterning was abnormal and it was a non-structural, non-traumatic. What actually happens is in this case the most important problem is with that there is no associated history of trauma or articular damage. As far as the capsule is concerned, there is this dysfunctional capsule because of the dysplasias which may be associated with it. Laxity is always bilateral, and mostly it is bilateral. Then the muscle patterning is also abnormal. This is actually what is happening is that there is maybe associated with dyskinetic functions of the muscle. As a result, they not be acting in unison. Rotator cuff, there are 4 muscles and they had to act in unison to create that sling effect, which may not be happening. Now briefly moving on to the first type, which is actually the acute type 1 injury, which was the traumatic structural injury, which actually produces an anterior instability. How it will produce anterior instability? That is by after having a trauma which produces anterior dislocation. Now if this is the patient, what exactly a trauma occurred, there was acute dislocation. This was not only damage the glenoid labrum, glenoid anterior part of the glenoid cavity, or which is forming the articular surface, as well as the capsule. So this usually produces a traumatic anterior instability which could be associated with type 1 polar injury, or this is the structural traumatic injury. What this is important diagram to understand before we move on further. Most common injury of anterior dislocation is that patient had a 90-degree of abduction with maximum external rotation. For example, this was the glenoid, this was the humeral head. When abduction occurred, and external rotation occurred. Maximum external rotation occurs and pushes the head forward. Now when this happens and head comes out anterior dislocation, if you keep on watching this, it goes like this and then it comes back like this. Now there are two types of injuries occurring. The labrum, which is attached on the anterior inferior aspect, this can get damaged, or even the anterior superior aspect as well. Mostly it is the anterior inferior lesion, which is called as the Bankart lesion. Then once the head comes out and goes back in like this, it's going to produce a bony injury over the posterior superior aspect of the head of humerus, which is also called as Hill-Sachs lesion. This is what is the diagram showing it out. Now the head has gone out from here, it externally rotated, and as this is the Hill-Sachs lesion on the posterior superior aspect, and this is the labral lesion which can actually occur associated with anterior translation or anterior dislocation of the head, which can now after reduction you can appreciate it where actually the problem occurred. It ruptured over here, it rotated around and eventually produces posterior superior Hill-Sachs lesion. Now what is actually happening is what type of lesions can occur with it. This could be osseous Bankart, this could be ligamentous Bankart as well, or this could be even a Hegel lesion which may be associated with anterior dislocation, which later on may produce anterior instability, which Hegel is actually humeral anterior glenohumeral ligament injury. Then there is ellipsa lesion which may be associated with it, which is actually anterior labrum posterior superior injury. Also this may be associated with these lesions as well, as you can appreciate it in this diagram. Now continuing with the post-traumatic, the classical Bankart is actually called as the ligamentous Bankart. What happens is there is anterior inferior labral injury along with the anterior dislocation of the humeral head and produces a posterior superior Hill-Sachs lesion over the head of the humerus. Now coming to clinical features, what happens when this is post-operative? There is always history of trauma, and if you search out the previous documents, probably there will be anterior dislocation as well. Usually patient complains of it that there was injury, let's say 6 months, a year ago, which got better, he was placed in a sling, also all okay. Later on, now he feels whenever during the daily activities or for example during the playing activities, he feels as if the shoulder is giving way and it's going to go anteriorly again. This is usually associated with acute dislocation which may be present which happened 6 months or 1 year ago. There may be a recurrent dislocation as well. Usually patient also comes up and complains that in last 6 months there may be 4 episodes or 6 episodes of a dislocation of the shoulder. Or there is instability, like the patient complains of that this giving way feeling, that's probably head is going to come out, although it does not comes out, but it subluxates quite a bit and quite oftenly. Now recurrent subluxation, this may be associated with shoulder pain. Most commonly it is the anterior shoulder pain. There may be associated with dead arm syndrome, when usually patient may feel that as if this is actually the arm is just hanging down because of increased apprehension that it's just going to come out and going to fall out. This is the situation. This may be associated with rotator cuff tears as well, or rotator cuff syndrome may be present as well. Why? Because this once the anterior dislocation takes place, this may be problematic, not only associated Bankart lesion which involves the labrum and the capsule mainly, or there may be bony Bankart which involves the article surface of the glenoid. There may be associated rotator cuff injuries as well, and patient may be actually coming with a rotator cuff syndrome. Other are supraspinatus tendinitis. Why it is occurring? Because once the tear develops, it may propagate further from anterior inferior to anterior superior area, and it can result in supraspinatus tendinitis, and patients may come up with problems like whenever external rotating, there is actually increased pain which is happening over the anterior superior aspect of the shoulder joint. Now coming to the test, once you get this kind of a patient, because this rotator cuff syndrome, instability, impingement, they usually have some clinical features in common. So you need to be absolutely sure whether it's syndrome, it's impingement, it's instability, or it's just subluxation, what exactly it is. The first and foremost clinical test is usually the apprehension test. In apprehension test, the patient is sitting comfortably, the examiner is on the back, the arm is in 90 degree of abduction with maximum external rotation, and you push the humeral head anteriorly. As you push the head anteriorly, the patient is actually wincing, or the patient complains that he feels like if the head is coming out. And then when you push it back, this is called as relocation. He or she becomes comfortable now that actually head has gone back in. Other way of doing it is actually is fulcrum test. The difference is, in this test the patient is actually lying downwards with arm and for 90 degree of abduction and maximum external rotation. You are actually again pushing that anteriorly but from behind, and as a result, as you push the head upwards and dislocates or subluxates anteriorly, the patient feels as if the shoulder is giving way. Other tests can also be done. Drawer test is also kind of a similar test. The main mechanism is the same. That is that you want to draw the head of the humerus anteriorly, and if it subluxates or displaces quite a bit, this is actually an indication that there is definitely anterior instability. The way of doing it is actually this position in 45 degree of abduction and external rotation. You push the arm towards you and keeping the hand over here. If the head is coming and touching the palm of your hand, most likely this is the anterior instability which will be associated with the Bankart lesion. Now, once we diagnose the anterior instability, we need to diagnose where exactly is the problem. Is it isolated Bankart lesion? Is it associated with the anterior capsule rupture? Is it associated with rotator cuff tear as well or not? Or is it there is bony Bankart as well? Maybe a malunited or an articular surface fracture of the glenoid as well. For that, you have to go for X-rays, and this is an X-ray which is classically showing a Hill-Sachs lesion on the humeral head, which is most likely a pathognomic of a Bankart lesion. If there is a Hill-Sachs lesion in humeral head despite articular incongruity, most likely there will be definitely a ligamentous Bankart which may be visible on the MRI. This is also another form of it. If you see, this is due to this anterior capsule tear, what is actually the head is subluxated downward, and sulcus sign actually becomes positive because the head comes down, and due to the injury to these inferior glenohumeral ligaments as well, and as a result you can appreciate there's a large gap between the acromion and the head of the humerus. Then other options include CT as well as MRI. Most oftenly you have to go for an MRI because soft tissue injury may be associated and which will be more easily visible on the MRI. If you see this situation over here, this is the glenoid cavity. This is the area where actually the long head of bicep is actually occurring, and you can appreciate the labrum which is attached to it is actually ruptured. There is increased edema and fluid collection over here as well. Most likely this is producing a Bankart lesion. This is also another view of it, and you can appreciate it over here. The labrum is actually quite not completely torn but partially torn, with associated increase in the capsular volume, which may be eventually leading to anterior laxity and instability. This is another way of it producing. You can appreciate the Hill-Sachs lesion which has been produced on the posterior superior aspect of the humeral head, as well as anteriorly you can appreciate the Bankart lesion. Now, what is the way of doing it? The arthroscopy can be is kind of a double-edged sword, that you can go for diagnostic arthroscopy to confirm your diagnosis, and once you have confirmed it, you can actually treat it there and then. The most commonly nowadays, this polar type 1 injury in which it's traumatic structural problem is usually treated with arthroscopic repair, which is usually done by help of an shoulder arthroscopy. What is the operative treatment? One option is if it's a Bankart lesion. If it's an osseous Bankart, you need to fix the articular surface back as well. Most commonly, it's the ligamentous Bankart, in which you can suture back it to the labrum by using a suture technique, which is very common. Mostly, it is in the anterior inferior portion. Sutures can be applied and anchored into the glenoid labral bone, and then it can be reapplied to so that the labrum is anchored back or sutured back to the glenoid bone, as you can appreciate it over in this diagram. Now coming to the operative treatment, other options which was more commonly used few years back was actually the operative treatment. Initially, if it was a Bankart injury, this was done, open repair of the Bankart was done. But nowadays, most commonly, all the anterior instability due to acute trauma or acute Bankart lesion is actually done arthroscopically. But if it is recurrent instability or recurrent dislocations, then we may have to go for some form of non-anatomical repairs as well. There are certain surgeries like putty-plat, which was of historical value. Nowadays, they have become obsolete. But certain procedures such as Latarjet or even the Latarjet-Bastow procedure are of significance that may require a non-anatomic repair. What is actually in Latarjet-Bastow Latarjet, the coracoid is taken out and it is actually displaced anteriorly along with the repair of the capsule as well as the Bankart lesion. Now, if supposing this is actually a glenoid cavity, this is the portion which is anterior inferior portion which is deficient. The coracoid has been pushed back right over here. It gives it a bony block, and then the head is relocated. It cannot come out because there is a bony block anterior inferiorly which compensates for the bony Bankart lesion, which has actually resulted in the fracture of the anterior inferior articular cartilage. That is with the mechanism of Bastow-Latarjet. Other is use of method is correcting to reduce the retroversion angle of the humeral head. If the problem is with increased retroversion of the humerus, this would result in increased posterior dislocation. Therefore, osteotomy in the proximal humerus can be performed to decrease that retroversion, and we can or increase the retroversion so that it does not actually dislocate more anteriorly. Then other options is actually the Bankart operation with anterior capsulorrhaphy. This was more commonly done few years back because the open procedure for the Bankart lesion is actually used and making an incision over the anterior superior aspect of the shoulder joint, going into the joint, repairing the Bankart and putting it back into the glenoid, as well as repairing the capsule. But nowadays this will be more replaced by arthroscopic repair, which is much better as compared to and has a better results as compared to the open Bankart repair. Now coming to the polar types 2 and 3. Polar type 2 and 3 are actually subclassified or actually classified in one form is called as multi-directional instability. Why they are called multi-directional? Because they're associated with laxity, muscle battening problems. There may be glenoid dysplasia, there may be increased retroversion or anteversion of the humeral head, which may be predisposing it to a structural type of atraumatic instability. Therefore, they are collectively termed as multi-directional instability of the shoulder joint. Usually, this is called as loose shoulder or problem lax shoulder. There is a history of voluntary dislocation as well. The patient may complain of it that without any trauma, I can dislocate my shoulder and relocate it back in. This is actually showing that the capsule is actually lax and actually the head can easily come out and go back in. Or this may be associated with habitual dislocation, which is very common in these kind of patients. Coming to the features, in atraumatic structural multidirectional instability, the most commonly it is actually acquired multidirectional stability. Why I'm calling it acquired? Because this may be secondary to some form of trauma which happened, which was treated, but later on the capsular laxity and tear which may have occurred along with it and provided there was also associated rotator cuff injury which was not properly addressed, this may produce something like a multidirectional or global instability in which head can go in any direction, or it may be resulting in a fatigue in the stabilizing muscle as well, and which the muscle patterning is really not normal. Includes patient with benign hypermobility syndrome as well. For example, if a patient has an Ehlers-Danlos syndrome, they have tendency to have an hyperlaxity at the joints, and they may be habitual of dislocating or relocating their shoulder either anteriorly or posteriorly, and this may be associated with glenoid dysplasia. The problem is actually the glenoid is so small that the head cannot actually properly stay over there, despite all the muscles were providing the stability and the ligaments were providing stability. Despite this, actually the head just dislocates quite quickly. Now coming to the treatment of atraumatic structural instability, usually it's multidirectional, and the common form is always remembered two mnemonics. One is the TUBS, another is the embry. TUB stands for if it is traumatic, unidirectional, Bankart lesion usually requires a Bankart surgery. That is the TUBS. Then it comes the embry. It is usually atraumatic, multidirectional, with bilateral, usually requires rehabilitation and inferior capsular shift. So the mainstay with atraumatic structural instability is to actually address the structural problem along with the rehabilitation and capsulorrhaphy, which includes physical activity modification. For example, what is dislocating the shoulder should be avoided. For example, if patient is having plays a game which involves throwing and this results in a dislocation, he or she should avoid that throwing mechanisms. Other is dedicated physiotherapy in form of rehabilitation, so that the muscles are strengthened further, so that they can reduce the effect of actually the movement of the head out of the glenoid. Then is the capsular shift. Capsular shift is actually done to tighten the capsule, so it actually further increases the static stability of the joint, so that the head does not comes out again and again. Other is mostly nowadays even this capsular shift is actually done by arthroscopic surgery. Now coming to the habitual subluxation. Usually this is associated with those conditions in which the patient has actually a hypermobility or hyperlaxity syndrome, such as Ehlers-Danlos syndrome. In this kind of a situation, this is also atraumatic and usually is multidirectional. So the most important treatment is usually the open surgery and informing after the rehabilitation to go for inferior capsular shift. This is the important point is in this kind of ways to regain the normal neuromuscular control. If this maybe muscle patterning is abnormal, you need to have a dedicated neuromuscular rehabilitation so that they regain the normal neuromuscular control over that body. Then you need a specialist shoulder physiotherapist so that they can not only provide strengthening exercises, but neuromuscular control over the muscle becomes very good. Later on, you need an occupational therapist and psychologist as well, so that it can help them not to get into kind of a situation where there is actually chances of increased dislocation. And then you need an occupational therapist as well, so that it can provide ways where they can do all these conditions or situations can be avoided, which can produce or which occupation maneuvers which can produce this dislocation. And lastly, you need a shoulder surgeon, especially the orthopedic surgeon as well, to do that surgery in which the inferior capsular shift can be performed and capsule can be tightened so that to avoid atraumatic non-structural instability or associated with habitual dislocation. Now I told you there is a specific lesion called as inferior subluxation and inferior dislocation. It's highly rare. And usually when we classify shoulder dislocation, we classify into anterior and posterior most commonly. Inferior is quite less than 0.5%. What happens is, this is why it is rare, because this sort of situation rarely occurs. It has to be this, that if something is falling on the top and patient arm is abducted and extended in external rotation above the head, in this situation, if the force is directed from this direction, this would produce the inferior dislocation of the shoulder joint. That is why this inferior dislocation is highly rare, or inferior subluxation as well. And this classical presentation of the patient is that patient comes in this direction because the head is down, it cannot bring the arm in. So usually the first and foremost is always the patient is keeping the arm above the head, and when you try to bring it back, it's actually quite painful. As I told you that usually this is the glenoid cavity, and actually inferiorly the capsule is quite thin as well. So there is increased chances of subluxation or dislocation inferiorly in this sort of a situation. In imaging, if you see the imaging, is first and foremost you need to look at the AP view, whether it is going down or not. And it may present like this, in which there is anterior inferior dislocation, which can be appreciated over here in this X-ray. Then once we diagnose it, whether it's inferior subluxation or dislocation, then comes the treatment. The treatment, if it's complete dislocation, the first and foremost is always close reduction under general anesthesia. That is, under sedation is absolute treatment. But if it is only subluxation and it is associated with a kind of a laxity that had a tendency to come down but not completely dislocate, then that can be treated with physiotherapy and inferior capsular shift or reefing. That is, that inferior capsule can be tightened arthroscopically or via open technique, and so that the head does not actually goes down again and again. Now coming to the posterior instability, as I told you, most commonly almost 70 to 80% of the time it's the anterior. In 10 to 15% of the cases it's the posterior instability. Why? Because it is associated with specific disorders such as for example, if there is electrocution injury, person has suffered sudden jolt or sudden problem, which may be occurring like in electrocution, or which may be due to in epileptics as well. For example, if patient has suffered from an epileptic fit, this may relate to in some form of posterior dislocation, or it could be due to the associated with the proximal humerus fracture. Now, in this kind of a fracture, the force may be acting from anteriorly. Once it has fractured the neck of the humerus, this head can dislocate posteriorly as well. Or it may be associated with a recurrent instability, especially in the posterior subluxation, which may be associated with recurrent instability. For example, patient had suffered once a posterior dislocation, and later on it has developed laxity, and eventually once the patient complains of it, then as the patient forward flexes it, it looks like if the shoulder is going backward and giving way. This is a classical example of posterior laxity, eventually may be associated with posterior traumatic dislocation. Now coming to the acute posterior dislocation, usually the injury mechanism will tell you if the mechanism of action is such that the patient arm was in forward flexion, was trying to stop something, and the force was acting from forward in this position. When elbow was in extension, all the force would be acting on the head and would actually push the head backward. Classically, if you see, this is the kind of a light bulb appearance of the humerus, because normally there is a greater tuberosity and lesser tuberosity on the one side, because as they are gone backwards, this classically gives the light bulb appearance in which there is a posterior dislocation of the shoulder joint. This may be associated, if it is acutely reduced, this may result in the damage of the posterior labrum as well as the capsule, and patient may present with recurrent episodes of dislocation, which may be posterior, or recurrent episodes of posterior subluxation as well. And in that case, there is maybe like this sort of a situation. If you see this X-ray, head appears to be gone back. As you can appreciate, the article surface over there looks empty, but this part of the surface is still intact with and in contact with the head, and probably this is subluxation and due to posterior instability, not with apparent dislocation. Now, there are different tests to confirm the posterior instability as well. One is an apprehension test. Same mechanism, the arm is in forward flexion in 90 degree of forward flexion with maximally adducted. You push it backward and the patient may complain of it that head is going out. Or one way is that you can put your hand over here, and you can, when you push it back, you can feel the head of the humerus hitting it on the palm of your hand. This is an indication that there is head of humerus unstable and actually dislocates quite easily. Other test is the drawer test, which could be done for the anterior as well as the posterior stability. The one way is the arm is lying side by side in 0 degree of adduction, and by the use of thumb and index finger, you can either push this head anteriorly or posteriorly. And if it's unstable, if it's posteriorly unstable, it will easily come out, or it will go out anteriorly if it is anteriorly unstable. Then comes the imaging for posterior instability. Usually an X-rays usually show some form of subluxation. If you can appreciate it over here, probably only the increased retroversion of the humerus is visible, although there is no frank subluxation or dislocation is seen. But when you get an CT or MRI, this is the situation. Can you appreciate the dent, which is probably due to the traumatic injury in the glenoid articular surface? And if you see it over here in the a large articular surface fracture of the on anterior aspect of the humerus as well. Now this means there was an acute posterior dislocation which was reduced, but it actually resulted in posterior instability. Now coming to the treatment. Treatment involves, depending upon what is exactly the cause of the posterior instability and what is actually the most affecting part. If it is not associated with excessive retroversion, then probably we can only go for treatment such as surgery and to repair the labrum as well as the capsule. But if it is associated with lot of retroversion, then we may have to go for some form of glenoid osteotomy, actually, because if this is happening, if instead of having a bit of a retroversion, head is going out like this, one way is to perform an osteotomy and make it a little anteverted so that head does not goes out. Or other option is actually to do an osteotomy of the proximal humerus in such a way that instead of retroversion, it can increase slight anteversion, and that would actually decrease the chances of posterior instability and dislocation. Or there is a soft tissue reconstruction as well, which actually involves the repair of all the labrum which is acting posteriorly, and the capsular reefing, and as well as tightening of the posterior capsule. In this video, we have mainly discussed the problems which may be associated with shoulder instability. Shoulder instability is usually secondary to some form of a shoulder trauma, which may be leading to some form of dislocation. Most commonly, the anterior shoulder instability is secondary to traumatic anterior dislocation, which may have occurred maybe a few months or a few years ago. And patient will be complaining of either the anterior subluxation or anterior recurrent dislocation in the shoulder. Most common injury associated with acute anterior dislocation of the shoulder is actually the Bankart lesion, which is the anterior inferior rupture of the glenoid along with the anterior inferior capsule. Most importantly, it's traumatic, it's unilateral, and it requires a Bankart surgery, which was a few years back was performed with open Bankart repair, but nowadays the arthroscopic Bankart repair can be easily done. There's a term called a luxatio erecta, which is actually the inferior subluxation or dislocation of the head. Although it's very rare, but if it is associated with inferior instability, then inferior capsular reefing can also be done. There is a term for type 2 and type 3 polar injuries called as multidirectional instability. Multidirectional instability is usually multidirectional. It is atraumatic, and it may be so the treatment option is first and foremost the rehabilitation, so that patient have an aggressive physiotherapy, muscle strengthening exercises. Once that happens, patient can go for inferior capsular reefing. Posterior dislocation is far less as compared to the anterior dislocation when usually associated with epileptic fits or electrocution injury. But if posterior dislocation produces some form of posterior laxity, then surgery, which is most likely open or arthroscopic, can be done to tighten the capsule posteriorly, as well as performing osteotomy either at the humeral head or a glenoid articular surface, so that the posterior instability can be reduced. Thank you very much. Keep watching sqadia.com.